like not use the file, we can scrap it.
Yeah.
All right. And I'm Lauretta. I basically coordinate this monthly program. So without further ado, I'm going to turn it over to Julia, who is a very dear friend of mine that I don't see that much these days because she's out and about in the world. So right now she's in Kyrgyzstan, but I quote her often because she's always looking for the meaning in the qualitative, which I think a lot of people are not really stressing. At any rate, Julia, take it away.
Okay, well, thank you so much, Lauretta. It's lovely to be here, and it's lovely to see people who I've talked with so much about various kinds of nuances of qualitative research. Thank you very much for coming. It's wonderful that Tatiana could be here and Sakina, and we have meetings every Thursday where we come together and we talk about research that is ongoing. I just am delighted that I can share some of things that we've been doing over the last little while with you, and it will be really nice to hear your thoughts. So
do you want I'm sorry to interrupt, but do you want us to interrupt? Do you want us to post questions in the chat?
Yeah, please interrupt and put stuff into chat, like or not interrupt. You know, however it's best for you. I don't have a formal talk. I just have some things that I would like to share, and I also have some materials that I'll put on my screen and share the screen periodically when it's you know, it's fitting. So, and actually I will start by sharing the screen. Just give me 1 second for that to happen. Bear with me. So as I mentioned, and I hope that you can see the photograph in the on the screen. So that's us, and you can see here myself and Sheila and our colleagues from Ukraine. And so you can see Tatiana here, who is also on the call, and then Irina next to her between Sheila and Tatiana. That is our key collaborator who's actually been conducting those interviews that I will describe to you today. And then there are clinicians in the front row, and then in the back row, and then one gentleman who is the third from the left in the back row is our member of the community working group that we established, and he is an older adult living with HIV. And this is the meeting that we had on the 18th of October, 2021. That was the first time after the pandemic that we could travel to Ukraine. And we launched our R21 project ROST, which is a peer navigation adaptation for people living with HIV who are older. And that is our community working group that we established about just before the pandemic started to help us develop research questions and guide us in our work and help us liaise with the community. And you know, it's a forum for us to discuss questions together and come up with ideas and solutions, and we edify one another. So it was a very happy moment, and we really were very glad that finally the pandemic was kind of winding down, and so we had a lot of energy going forward. So that's something that, you know, we really cherish. And so I think that that spirit of being together and of continuing to do good work has been what helped us to stay connected. And over the pandemic, it was very difficult for us, of course, to stay connected because we couldn't see each other, but we kept in touch very vigorously over Zoom, and we had regular team meetings all throughout COVID-19 time. And we did a lot of field work during that time, also by virtual means, mostly by phone, because our participants who are older adults with HIV, and also clinicians, they don't particularly like Zoom technology because it's too cumbersome. It takes up too much time, and you can kind of like talk on the phone as you are on the go. So it's a preferred way of engagement, and it worked extremely well. So we did a lot of field work over the pandemic. Some of that we published, some of that is still in the pipeline. But anyhow, we had that process down to the T. We knew how to reach participants, how to recruit them, how to interact with them, how they respond to that, what they like, what they don't like, you know, how to handle all sorts of situations where they are upset by whatever, you know, like all the big thing. And then also we had the process of getting them participant compensation by online bank transfer. So we knew all of that. And that's exactly what we did during the war. So we thought when the war started, and we had our first meeting on the 25th of February, and that was when it was just like very raw, and we were, you know, like we just didn't know how things would be going. And we had our first meeting, and in the at the time Irina was she couldn't stay for the whole meeting, so she said that there was an air raid and she had to go downstairs, you know, into the basement. And you know, we kind of made a pledge that we will just keep meeting and, you know, helping one another emotionally. You know, work seemed to be therapeutic because it gave us all a sense of something to hold on to, well, in various kinds of ways. And, you know, I'm sure that psychiatrists of war understand that much better than I do, and they have written volumes about it. But sort of in our own experience, we felt that we wanted a sense of normalcy, all of us. We wanted to pursue our goal of giving our best to the work that can help the health and well-being of vulnerable individuals. And we wanted to stay together. And also we thought that it was, quite frankly, just something that needs to be studied and to be shared with the world because it was so important. And we were, you know, really wondering, you know, how our participants and our clinicians and just everybody was coping. And if we could learn from, you know, from that, if we could find some way to provide help immediately or in the long term. And so that was our, you know, sort of spirit of getting the goals for fieldwork. So during that first meeting, we didn't yet set the goal for fieldwork during the war because we didn't know if there would be a war or if it would be just a short, you know, armed conflict. And then we didn't have our meeting the next Thursday because it just it was impossible. But then we had a meeting, you know, kind of like 2 weeks into the war, and every week since then. We never missed one single week, and we all came together. So we were able to, you know, to meet as a group. And about maybe, I would say somewhat mid-March, we started talking about fieldwork. So we said that we need to, you know, we need to get going, and we need to just, you know, use this moment and not delay it, because, you know, you have to really literally live here and now. You might not have another opportunity. You don't know if you're going to be alive or not the next day. And so we decided we will just start, you know, doing field work the same way as we did during COVID. And so we decided we'll start by reaching out to our community working group members, some of whom you see here on this photo. And we would start by reaching out to clinicians and also get their help in reaching out to some of the HIV patients, older patients with HIV, who they can link us to, recommend to us. And then we would have an interview guide that would ask them about their experiences, if they have any direct experience of any kind of violence, or if they have become refugees, or if they have been evacuated or evacuated themselves. And then also, of course, questions about their participation in HIV care, in any other kind of care for other chronic conditions. And then if clinicians were able to provide HIV care. And so there were a few interesting articles that were published early during the war, in the early sort of like March. One of those pieces was, I think, March 9th, published by Michelle Kazachkin in The Telegraph. And it was kind of like the sky is falling type of piece, which talked about lamenting, the decades of good effort in Ukraine, of, work towards eradicating HIV and other significant diseases sort of like going down the drain, because he was afraid that everything will be disrupted and that will all be gone. And that was the fear. And then there were other pieces like Rick Altis published like March 22nd, I think. There was a piece in the Lancet Global Health, I believe, which talked about systemic issues and also, gave some suggestions about what could be done, or kind of like wish list, of things that could be done to prevent the disruptions that Michelle Kazachkin and others have been worried about, in HIV care in Ukraine and also in the region more generally. But that was rather, to our minds, was like what we want the world to be or what we fear the world is, and not what the world really is. And so we wanted to see the sort of naked reality, of people, not some kind of blockbuster style, but the real stuff. So we ended up thinking that, our sample would be kind of like a target number of 10 people, because it seems to be a nice round number. And it's something realistic because, like none of us actually had any experience in like humanitarian health or working in humanitarian settings. We did not plan to be researching humanitarian settings. It's just that, our site and for our colleagues, their homeland became a humanitarian setting. So we just had to roll with the punches. And so we thought that 10 would be a good enough number. It would, of course, be increased if we were able to get a hold of people, but also depending on how much effort it would take, because we didn't know if people would be happy to be interviewed. And we decided we'll just give it a shot. And if they are, not reachable, if it's too difficult, if it's too painful, or if they're upset, or if they just, wouldn't answer, we wouldn't do it. So we would kind of like, go with the reality. And we also thought that we would keep going if the stories would keep being all unique and, saturation is not reached. So if like we didn't have any kind of like consistent narrative altogether, then we would keep going. So the first interviews were done, I believe, on the 27th of March, and then we went through April 8th. So I believe in that week and a half, that's when the interviews happened. So they were all conducted by our colleague Irina, and they were all done by phone, and they were audio recorded. Consent was done by phone, the same way exactly how we did it during COVID. And then they were transcribed. And so I now have the transcripts of those interviews, and we are not going to be translating them just for, purposes of this analysis, because it's going to be like a repeat kind of type of thing, or as repeat and as quick as we can physically manage. Okay, so each interview lasted about at least half an hour. Some of them were longer. And again, in terms of the process, we consulted with few colleagues who did research in humanitarian settings, but really our best advisors were our colleagues from Ukraine, because they were right there. They could tell, what was going on, and if it was safe to conduct those interviews from every point of view. And so we said to our interviewer and to the participants, in this sort of like spiel that we use, that it's up to them, to decide if they're in a safe spot, however safe you can define safety, to take that call and to have the interview, and they can interrupt at any moment, like the usual thing. And so the first thing that we learned is that people really wanted to have their story asked and to be heard. We had people tell us after being interviewed how grateful they were for being approached, how much they appreciated the opportunity to speak with Irina. But also they admitted that it was a therapeutic process for them, because they made their thoughts, like once they were out there, it was a relief, but also they thought that it was something valuable. It just was this kind of connection with a human in this deep understanding and empathy and, and everything else. So we were very, very glad that even the process of learning about, these people's experiences was worthwhile. And Irina also shared with us how she felt, because we had a conversation. She and I had a conversation after each interview, and she shared with me her, emotions and just like, how was it? And so she said that some interviews were darker than others, and some interviews were more positive in the sense of people had more acceptance and sort of a better sense of direction of how they thought their life would be going on, from that point onwards, whereas others were much more lost and confused. So basically, of course, like everybody was processing what they were experiencing in different ways, but also people had very different insights into what was going on. So now what I will share is just this little thing that can you see the Word document on the screen now?
It was on and then it's now off again.
Okay.
You had a table, I thought.
Yeah, so not the table, but I'm trying to share a Word document. Anyhow, maybe I shouldn't, because I can just like tell you what it is. So basically, I'll tell you some distillation of the stories so far that don't give them justice necessarily, but then I'll kind of like go a little bit deeper into each. So out of those 10 individuals that we spoke with, 5 people were persons with HIV who were older, and 5 were clinicians. And so among the persons with HIV who were older, we had 4 men and 1 woman. And the oldest person was 77 years old, and the youngest person was 54 years old, I believe. And so then among the clinicians, we had 3 women and 2 men. And they also had different responsibilities. So all of them had something to do with HIV care. And one doctor was an HIV doctor who was sort of the head of the one of the HIV sites in Kiev. One person was a psychologist, and one person was a social worker. All these were women, and they worked in HIV care, and they were quite experienced, so they worked for a while. And then the 2 men one was a frontline doctor and one was the clinical director, and they both were from the addiction treatment clinic that also has like a full-scale HIV care department. So what we found in sort of a very tight nutshell, there were 4 things that really need to be emphasized. So one thing is that the majority of older persons with HIV stayed in Kiev and they did not evacuate. And that was not just the story of our participants, it was the story that the participants said about people they know who have HIV and who are also in Kiev. And also the doctors were saying that the majority of their older patients stayed put. So the reasons for that included different things. And one big thing was the impaired mobility. So these people just did not have the capacity to walk very far. They had issues with their legs. They could hardly walk like up and down the stairs if they were air raids, and they actually stopped doing that just because it was too much. And their health conditions were such that they needed extensive help if they were to evacuate, but they didn't have that extensive help. And they didn't have a lot of financial resources, and they also didn't have a lot of instrumental help from others, to be able to go somewhere. One participant who did evacuate did so because her daughter took her with her, but our other participants said that family members who left, who were not, their children, they were extended family members, they never invited them to come with them. And, they just they stayed behind. In some cases, they were invited, but they decided that their emotional attachment to home and caregiving responsibilities for pets, for example, cats and such, were really things that they just didn't want to forego at this point. And combined with the lack of income, fear of unknown, and the emotional attachment to home, that kind of made their decision. Also, there was a very, very important factor that was wishing to stay close to their trusted HIV and other healthcare providers. So what is happening with those older adults is that they develop very important relationships with their HIV doctors and generally clinicians in HIV care. For those who also have comorbid addictions, that includes addiction doctors into this mix. And these people are pretty much their confidants, sometimes their only confidants that they rely on for any medical help in general. So they would just ask those doctors for anything to do with their diabetes, with their cardiovascular diseases, with their conditions. Some of them just wouldn't even go to their primary care physician because they wouldn't want to sort of like be known as a person who has HIV by those doctors. So the fewer people recognize them as people with HIV, the better. So it's kind of like a disclosure of HIV status issue where they just don't want that, to have that experience of being reminded of that over and over and over again. And if they go to a new place, that means that a new person would be looking at them and they would know that they have HIV status, and that's not a pleasant thing. And then for a lot of them, that's a deciding factor. So they just, it's not like the logistics of trying to get HIV care from, another center somewhere else in Ukraine, where theoretically they were, possible facilities to obtain that care, but it was just that they didn't like the experience of, that I've already described. But that again, like some few people, but they were such that didn't mind it quite as much and that did, kind of try to do it. So the other thing that was very important is that this was very different from the experience of younger people with HIV, a lot of whom evacuated. And so for them, the logistics of getting their ART medications, if they were inside Ukraine, became complicated because they had to rely on a lot of like volunteer coordination things where the doctor would call somebody who might be taking the bus to another city, and that person would be meeting a friend of theirs or a cousin of a friend, and like that would be just like done by volunteer effort. And some mailing would also happen, but also some redistribution of patients between centers. But basically it was all done through like word of mouth. So young people, some of them relocated and evacuated, but not older adults with HIV. So the other thing that was important is that despite physical limitations, our older adults with HIV in their interviews manifested great presence of strength and resilience, spiritually, emotionally, and in every other way. So it's not surprising because older adults generally do better just by virtue of being older. So the older you get, the happier you are. That's sort of like gerontological literature's mantra. And that's very true because you kind of like have learned over your life to deal with negative things. And our older adults were also exhibiting that resilience in various kinds of ways, including by supporting others in their communities. And by community, I mean usually like their apartment buildings, so where they have, a whole bunch of families. Some of them might have evacuated, but the rest of them kind of like clubbed together to help one another in various kinds of ways. And they would be not providing any kind of like, physical help, but they would be emotionally available to their neighbors, to chat, to cheer one another up, to just like exchange a few words, that would be quite important for people. So I've already said that, HIV disclosure was a big topic, and to receive help with accessing ART in the context of war, there were instances that clinicians told us about, and the interviewees also told us about, that some older adults with HIV disclosed their HIV status to family for the very first time. because they could no longer kind of sneak out and, say, oh, I'm going to, I don't know, like do some shopping and then go and like pick up their tea, and nobody would be the wiser for that. Well, now it was not possible because of the curfews, because of all sorts of, logistical problems. The transportation wouldn't work, and they would be very conspicuous in having to need to go somewhere, so they needed to rely on others very often for help. And so they had to tell them about this. But also the fear of HIV status disclosure to new people, including clinicians, was a very big barrier for people who are older and who have HIV to consider evacuation from Kiev. So now the juicy part about the clinicians and about the HIV care continuation and sort of like what it was like and what it meant and how it was going on. So mind you, that's very important to remind that is as of early April. So things are better now. As I was told by clinicians that I have been in touch with. And there's some other things that are happening that I'll just tell you, like fresh news, like as of, I don't know, like half an hour ago. But as of April 8th, the situation was that the number of junior personnel in the HIV care was reduced dramatically. So that was for a number of reasons. One of that is because a lot of them were young women with children who evacuated. The second reason was that a lot of them lived outside of Kiev, quite far in some cases, and they could not travel during the war to their site of work because of roads being impenetrable and broken and danger and, and then like whatever, soldiers patrolling the roads or, all sorts of logistical impediments. So they could simply not travel to their site of work for weeks. That means that the clinics did not have nurses and janitors and nursing aides and social workers and psychologists. So these people were not being able to access. That was not such a problem for doctors because a lot of them either lived closer or they had their own cars. And so they were able to come to work. They were, in general, even though some patients evacuated, a lot of others came to the city from some other neighboring places or even from other parts of Ukraine. And so essentially it was about double the patient population per every clinician, but there would be about half or fewer clinicians at each site. So you can see that, it was like 4 times an increase in workload, something like that, like very big increase in workload. And of course, logistically, it was very complicated and it was just like very, very difficult. So what did people do? You can ask yourselves. And that's exactly what I was curious to learn. And so the answer was they just worked much, much harder to bridge all of these kinds of disruptions. And they did so extremely successfully so that there were no disruptions. They were stoically continuing to provide care, just, like Elastigirl, kind of stretching to superhuman capacity to cover every possible gap. So no gap was wide enough. They just mobilized, and that meant that they worked shifts and they would sleep on the job. And just like, they would come for 7 days at a time. They would leave from the facility. Sometimes they would take their small kids with them if they had no other person, take care of the kids, and they would just like take the kids there. Either like the bigger kid would, tend to the smaller kids, or, they just organize childcare, and they would just work around the clock with, little breaks to just like take some rest. So eventually, by the time we interviewed them at the first week of April, they said that it has become a little bit better, and they would be able to only come for like 3 or 4 days, at a time, not for 7 days. So they would work shifts and then they go home. The next shift would come, the next batch of clinicians would come, and then they would just rotate this way. So that also was enabling them to ensure pretty much like round-the-clock service of patients, because you never know like when a patient would be able to come, and so you need to have somewhere on site to meet them and help them. So in terms of medication shortages, that was not the biggest problem. There were some concerns about that, but really it was more just like procuring them, kind of like finding out, maybe moving them from side to side, but they were fine. Like, there were no reports in our accounts of clinicians about like they ran out. They were extremely ingenious ways of managing some problems. So, for example, in addiction treatment, there was an instance where, how do I start to describe it? So lots of things happened at the same time. On one hand, there were some patients who used to be on methadone, but they were not really regular patients of any, official clinic. They rather went to those sort of underground facilities where they could get a prescription for methadone and then buy that over, out of pocket at the pharmacy without having any kind of patient record in the system. So some people who were better off used that route. It was, legal enough. But then those clinics disappeared overnight. That's what the clinicians told us. So they just ran out of the city and abandoned everything. They stopped operating without any notice. So all the people who used to have those prescription medications did not anyway have a, they couldn't sort of like renew those prescriptions or fill those prescriptions in the pharmacies any longer. So they had to find some other way of getting their methadone, to avoid all the withdrawal symptoms. And then there were also some other people who came from away, and there were just a lot of strange people in Kiev, at the end of March and or throughout March. And it was a very unsafe time for clinicians because people started sort of like having rumors that there were supplies of methadone in their clinics, and they started to gather around in like gangs to try to storm those facilities, to take it by force, or just, to demand that they have it. So what the clinicians decided to do is to avoid danger to the staff, is that they decided to give out minimal doses that they could afford to give out to anyone who would just show up and claim that they needed it, without taking their name, without the passport, without anything. Just like you show up, you say you want it, here it is. If the supply is still available, because this way they tried to save lives and also to not be killed, maybe if there was a run onto this facility and there was a whole bunch of like young kids there also, like with their, with them. So that was what they did. And that seemed to be a very smart move, because a lot of these people, well, first of all, they avoided any kind of like conflict. But also a lot of these people came back and they actually decided to become registered patients. So at the end of the day, they had a whole new crop of regular, clients who were eager to be treated. And they avoided any kind of, like loss of human life or any other problem. So these examples of what they did, they of course show a lot of ingenuity, but you kind of like would ask yourself, I suppose, because I'm asking myself this question of, is it the new normal? Like what is happening next? For how long can this continue? For how long can people like, do those long shifts, leave on the job and, and sort of like keep going? Well, so far they've been doing that. And so far they've not yet dropped dead, or at least we haven't heard. But, can they go on like that for 6 months? Can they go on like that for 12 months? Would they have to? And then the other question, of course, is like, okay, well, what eventually there will be peace of some sort, whether, people want it or not, there will be peace at some point. And then, would there be more resources given to those HIV care and addiction treatment facilities? Or would, the government say, okay, well, you guys survived, so you might as well keep going, like you have half the staff, twice the patients, and then just great, good job, keep on going. So that's a question that is not yet answered, and that's not something that can be easily addressed, because that's like, what you do in a crisis, like when do you know is the crisis over or not? And how do you transition from this sort of like, up in arms to like, okay, well, now this is the everyday reality and we just have to keep, this is our new life and it's never going to be back to what it used to be before. And that's when we thought we were deprived of resources, when in fact it was like wonderful, it was the El Dorado of resources. So these are the questions that I'm asking myself, but I don't think that the clinicians are asking themselves those questions as yet, because they're just trying to hold the shop, you know, they're trying to take care of all their patients, and also they're now developing new things. And the new things, as we were told, include mental health services. So they do it in two ways. One is the general mental health care for everybody, and everybody means like literally everybody is in need of some kind of psychological help. So they are doing that in voluntary ways, like people who have skills, they're just offering themselves to those efforts, but they're not getting paid for that. So that's also a problem, because, you know, they need to somehow, you know, eat 3 times a day, preferably, but, you know, like to get the money. And a lot of people who have jobs, you know, like as freelance, like psychologists and whatnot, like now a lot of their clients are not able to pay them, you know, for those sessions. So they now do those volunteer work, but that's not really giving them an income. So it's a good, you know, civic sort of process of helping others, but it's very vulnerable for the psychologists who are in this position. And the second thing that is happening is that, you know, regular clinics such as addiction treatment clinic, they're developing the post-traumatic programs for people who are in need of help, and that includes people who have had some combat experience, or just general public who need to have some alleviation of their anxiety and stress and distress, and then just need, you know, need help psychologically. So that's up and running, or getting close to being up and running. So there are a few other things that were just, I guess, worth to mention. One thing that, you know, that I kind of like was one of the most challenging pieces of data that I read. And when I read it, I could not, you know, I was in tears because it broke my heart. So I will just share with you this little piece, and I did not put that on the slide, so I'll just have to read it out to you. So basically, that was an interview with one of our older adults with HIV. It's a person we know quite well, because he's a participant who has been helping us in various ways over the last 3 years by, you know, giving us feedback on our drafts of things, and, you know, coming to our meetings, and just an extremely helpful person. He was a very active person as well. He still is to an extent, but, you know, he has been the chairperson of one of the organizations in Kiev for people living with HIV, and providing services to them. He at some point was also a member of the city, not parliament, but sort of the, you know, the legislative body of the city administration. And he just, he was a very active, you know, very well socially connected person, but he has had a lot of health problems during the COVID pandemic. He also had his health crumble, and that was starting to help before the war, but during the war, of course, it didn't improve. And so his friend, he's gay, and his friend moved away because he had some family, you know, elsewhere. And so he decided to travel with them. And that meant a big loss emotionally for our participant, but also he felt very isolated and lonely, even though he didn't mind, you know, that his friend had to leave, but he felt very lonely. And there was this one piece where he described how he had to travel, you know, to the site where he had his cancer treatment, because of course it never rains but pours. And he said that he had to go 5 times or more to that facility, and their place is located quite far, and you have to take the public transportation. And he said that it's very difficult for him to walk because he has mobility problems. And then he was just saying, I went there and I took a taxi, and I was concerned that I might be late. And so I ordered a taxi. It wasn't too expensive. It was about 50 or 60 hryvnia, which is about $2 or $3. And he said that back, he didn't take a taxi back because it was still, you know, a sizable amount of money for him, but he decided to take a bus. And he would just take his time to walk from the hospital to the bus stop, and he was waiting there. And he said he was waiting there for about an hour because the schedule of buses became unpredictable with, you know, some buses just being taken off the schedule and other buses being used for like military purposes. And he said it was so cold. I felt so cold and so alone. When I read that, and I'm still like, I just cannot bear it, because when I see that picture of that man who I know very well, and he was standing there at the bus stop by himself, just like something snapped in me. So what I'm very, very happy to share is that, we had our team meeting after we read that interview. And so we decided we'll just offer him a little job, because we had a little bit of funding, that we could spare. And so we thought that maybe he could be a consultant for our project and help us with, analyzing those interview transcripts. And, it wouldn't be just like a charity, it would be an actual meaningful contribution, would really value his input, but it would be something for him to, to occupy himself with. And he was very grateful for this opportunity. And so he took up this offer. And so, I don't know, I felt a little bit better that I can't help everybody, and maybe this is not a huge amount of help, but at least it's more than nothing. So the other things that were mentioned by people is that they had problems with food. Food became in short supply, it was very expensive, and with their mobility challenges, it was very difficult to access. Neighbors helped a lot, but they were too proud to rely on neighbors' help all the time. But also neighbors tried to kind of buy them food and not take any money for that, and they just didn't want to let it be like that. So they often just declined. And the aid that was collected, were provided by the city was not always reaching participants easily, because there were all sorts of, imperfections, let's put it this way, that prevented people from being able to receive that aid in time or often enough, or just even maybe they were bypassed for whatever reason, and they didn't always know how to reach for that aid, where it would be distributed, or if they called, they would be told, oh, but you've already been, sent some humanitarian aid, and they said, oh no, but I haven't. And so there was some bureaucracy involved. So it was complicated, like it always is in those circumstances, or it's difficult to organize this perfectly. So people could not rely on that, for their well-being. So they do have a concern. So what I can also share with you is that, remember I told you that we've done some survey work among our older adults with HIV, and we had their wave of the survey, and we have 123 people in the panel, and we surveyed them 3 times. The last wave 3 happened, stopped on the 23rd of February 2022, and the war started the next day. So we have a just like natural baseline, and that survey includes information on there. I'll show you what it has information on. Just that's my last piece, and then I'll shut up and let you ask questions, make comments, and whatnot. So let me just share screen. Where is my survey? Here it is. Okay, so you should see a little table here. So that was done by Catherine Rich, who is our collaborator, and she did this sort of calculation of who we were able to reach. So we didn't reach the whole 123 participants. Some of them died by then, because the panel ran already for like 18 months or more since the beginning of COVID, or almost for 2 years. And then some were not to be reached, like they were lost to follow up. So we had 102 people here, and you can see the mean age, COVID, that was still important at the time, exposure to COVID test. So chronic conditions. So we had about like 3/4 of people had other chronic condition than HIV. Well, of course, it was a sample that had a lot of addictions by design. So history of SUD was half of the sample. Not that many people said that they used drugs in the last 6 months, but I just want to draw your attention to mental health. And so if we see here, We had the scales for depression, PHQ-9, and we had anxiety scales, GAD-7. And then if we see who had any symptoms, and that was about 40% for depression, any symptoms of depression, and about 33% for anxiety, any symptoms of anxiety. Not that many people had a severe or moderate. Some people had suicidal ideation though. So interestingly also, a lot of people, as you can see, like almost 80% worried about economy, and that was already before the war because of COVID. COVID has not been very kind to Ukraine. That economy dropped down quite significantly, but especially for older people, a lot of whom, just like our participant, whose story I just described to you, lost not just their health, but also their jobs, because a lot of these older adults worked part-time to supplement their more than modest pension, and they could no longer do that during COVID. And so their income went down quite considerably, but also the income of their family members could have suffered. And so a lot of people experienced worry about economy and inflation and purchase of goods and loss of job and things like that. However, quite a lot of people said that they had social support, and about a third said that they were willing to help others with HIV. So here we can see the trends in depression and anxiety. So here we can see that, it kind of like depression went down from early COVID pandemic to just before the war started. Not much, but a little bit. However, anxiety kind of like had a dip midway through COVID, and then it went back up to almost the same level as it was in the beginning of COVID. Now, all of that is pre-war, and we are now running the fourth wave, to which we added a whole bunch of questions about the war experiences, if they have had any, experience of seeing violence or being subjected to violence and things like that, if they have evacuated, what was happening to their addiction care, HIV care, and care for other things, like all of that stuff, but also food insecurity. And so to date, we, I believe, have surveyed 9 people. And so food insecurity was the biggest issue for them, so that's, out of all the war experiences, food insecurity is number one. But that doesn't mean that they don't have food now. It just means that they worry about it. So that's the thing that is the most worrisome thing for them, and the one that causes them the most distress. So that's something to consider. And we really hope that we will complete the data collection as fast as we can, so that we can compare it with the baseline, and we can see kind of like, where the biggest problems are. But also we want to see what happens with their ability to continue the HIV care and the care for other medications. So concerning the care for other medications, what our participants were telling us is that because they have to pay for them out of pocket, they kind of had to ration them. And so they would not take them as they should because they couldn't afford them, but they would just like take, for example, a medication for, I don't know, hypertension, or, some of them have diabetes, they need to take expensive vitamins. They can't afford them, to take them every day as they should. They take them maybe every other day, every third day, just to sort of like last, a bit longer. And they have decisions to make, like, do they pay for their, like, their fee for, like for their gas bill or their electricity bill, or do they, buy medications, or do they buy food? So it's kind of like that, and of course, during the war, it becomes even more difficult because prices go up, logistics disrupt, things become more expensive, more dangerous, more everything. So, but despite all that, they manage. And of course, clinicians are real heroes, and they are keeping people alive. So I think that that's pretty much all I could share. And to end my remarks, what we were thinking about is that, what are the implications of all of that? Like, we know the story, but what do we do about that? Like, what can be helped? So we asked people, what they think would be the most helpful thing. They gave us some suggestions. Some of them said that, money and help should go to those who have the most disability. And it would be very important to do something for mental health. But what struck me the most was the response of one clinician, and that is a woman doctor who provides care to now twice the population of patients with HIV. And she has lost, well, she used to have 4 staff altogether on her site herself, and a psychologist, and a nurse and a nursing aide. So now she has just one person there. So they're very, very understaffed. They were understaffed to begin with, but now they just like have almost nothing. And so she said, we don't need anything. And so the interviewer asked her many times the same question because she thought like maybe she didn't understand. And so she said, well, you know, if you had the possibility to get, you know, some support from part of that money that's collected by the international community, if you had some resources, you know, if you had this, if you had that. And she said, no, we don't need anything. We're just managing fine. And so to me, that was a really interesting statement. Like, what does it really mean? That's what Lauretta says that I like to ask, like, what does it really mean? So to me, that means an extreme burnout. That's number one. So she's so tired that, you know, even thinking about like where else could a next, you know, pair of hands or, you know, she just cannot think like that because she's just withered. And so, you know, kind of like you need to water at the root, you know, people like that, because they're the salt of the earth, but, you know, they would just break down at some point, you know. So like supporting those stalwart individuals who are extremely resilient, but who are just, you know, bearing it and, you know, and smiling is very important. And thinking about like how best to do it, it's very difficult because they are not able to even like accept that help, you know, because they're so tired. So that's it. I'll shut up, and then thank you so much for listening, for giving me the chance to rant about it.
So thank you, Julia. It was very interesting. I don't think you have one story. I think you have many stories to be told from the data, and hopefully you will be continuing to collect. Does anybody have any questions or comments that they'd like to make? I like to always get audience to talk first, if at all possible.
Oh, I was just going to say, hey, Julia, it's Meredith. I mean, this was just, I could just listen to your stories forever, really. Like, this was so wonderful to listen to. And I think this isn't really a question, but it's just, you happen to talk about something that actually has come up, I think, twice for me in the past 2 weeks with research studies, which is this sense of like, we are studying, but what are we actually doing, right? And like the example that you gave about the man who you hired into your research team, where you're just like, I know this is happening. We know this is happening. We know these stories. What do we actually do about it? That resonated with me a lot because this is coming up in a lot of our studies, right? Where we have participants saying like, well, this is great and I'm really happy to help, but what's going to happen next week, right? Where we, in research, we think years, and I don't know, that really just stood out with me. It gives me a lot to think about.
Yeah.
I mean, it's interesting, Meredith, you know, because what resonated for me in that story and brought me back a few decades was my experience in Africa, but that this experience happens all over the world, I am sure, that you have a crisis, you have a local crisis, and the people who are there to help, that they're the regular providers that are there on site, and then you have the researchers or the international community coming in to help out. There is an ethical dilemma for them of, you know, in our case, it was people would be starving at a certain time of the year, and was it right for us to eat? You know, it's that desire to do good, but you need to take care of yourself as well if you are to serve the community, either as a researcher or a provider. So that was the story that kind of my reaction to that story.
Right. Yeah, we're thinking a lot about, you know, what would be the so for the paper, but just live, more importantly than in the paper, what can be the recommendations, you know, given how resilient people are, and, you know, what could do good given that there is a lot of mess, you know, there are logistical challenges, things are in flux, you know, so a lot of people are doing the best they can, but, you know, like, can you do it sort of through the local level, and how you do it, like from bottom up, from top down, you know, like what would be the realistic things that would change things in a way that is possible, you know, rather than just having a wish list of what we hope could be achieved.
One of the questions I had about kind of to the point of what can we do now, I was just kind of curious about how much infrastructure in terms of access to the internet is for possibly, you know, for the people to access mHealth programs beyond just meeting with your provider remotely, but are there supportive, I know for, you know, substance use, there's all sorts of supportive, and for mental health applications out there. Now, how many of them are in Russian, let alone in Ukrainian? That's another question. And then there's also the question of, is it feasible that people could access this and you could leverage that kind of technology?
Well, I mean, I could start, and then maybe Tatiana, if you're here, you could, you know, comment on that more in depth than I. So internet connection generally is quite good for the most part, at least in the places where we were doing field work. But I cannot say if that's true for the whole of Ukraine. It's probably also kind of like touch and go in some places and much better in other places. But you know, we didn't have disruptions because of poor internet connection. That's sort of, yeah, Tatiana, maybe you could comment.
Yeah, I can just comment that internet access in Ukraine is quite good. And as you know, of course, we were doing the field work and data collection or online, I mean, by the phone or face-to-face in the facilities where definitely internet connection was accessible. And as you know, even in the bomb shelters, even in metro and in the bomb shelters, internet connection was provided in Ukraine, even during missile attacks in Kiev and in large cities. So we didn't have, I think, problems with that.
There's two parts to that question, Yulia and Tatiana. There is, and thank you for answering that the connection was good or good enough, which is a great thing to note. But the other part of the question is, are there applications in Russian or Ukrainian, mHealth, mental health ones, or supportive ones? Are there applications in existence that can help? I know that I've worked with tobacco users. I've worked with people with chronic pain, where part of the intervention is having access to these mobile applications. That's the other part of the question.
I can say that we don't have such applications yet.
Yeah.
I mean, so far, some programs are being introduced lately, like CITA, you know, probably this program of Johns Hopkins University and MH Health, not MH Health, MHGAP, WHO program. But they are provided through trained professionals or lay professionals, like CITA, for example. And so not through some mobile applications yet.
Yeah, we also have a grant that's, we are all on it, that Sheila and I and Alexander, our colleague, and also somebody at the University of Virginia wrote about exactly like an mHealth application for older adults with HIV based on positive links that was successfully used in the US and some other places. But that's not yet, you know, up and running. So that's just something that we wrote and, you know, received a score for, and who knows what happens next. So there are things in the pipeline, you know, and I actually thought about that, you know, when this older man was describing how he stood on the bus stop, feeling cold, and that wasn't just physical cold, I think, you know, the way because I listened to the audio file as well, and, you know, the way he described it was just like, you know, it froze me to the bone marrow. So I thought that if he had an app where he could connect to a community of peers, maybe it would have been better, you know, he would have felt warmer at heart because of that. Definitely worth, you know, pursuing, I think.
Yeah. No, it's a hard job you all have. I mean, when there are crises, it makes our job that's hard enough even harder.
Right.
I was going to ask also about. So this project had two crises that occurred, two unanticipated problems. First, you had COVID, and then you had the war. And I wanted to ask you all, how do you think, if at all, how do you think your experience of that first crisis, the COVID crisis, helped you or didn't help you with the next crisis very different crisis that you faced?
Yeah. Well, I remember, Tatiana, when we were talking how good it was. You know, we didn't know during COVID how lucky we were and what a happy time it was, right? Because we thought we hit the bottom and then somebody knocked from the bottom up. Maybe you can say what you think and then I could add.
It's very difficult to say how COVID helped, but definitely during these 2 years, we got used to, the system rearranged in some way, and we got used to taking more advantage from the remote, taking care and health services, and even as we work a lot with for example, providing MAT to drug-dependent persons. If before COVID, about 50% of them received MAT for take-home dosages. Since COVID started, in some places, at some sites, 100%, and average in the country, on average, 80% now are receiving MAT for home use. And also primary care physicians, they started doing much more consultations, counseling online and on the phone, and it became like a norm. And definitely all these rearrangements, they helped a lot to adjust to this new, very, very bad, like our horrible reality.
So there was resilience in the patients and in the providers and in the researchers.
Definitely.
Yeah, but as I said, also there was this level of fatigue, right? So that when you have,
absolutely. Yes, Yulia, absolutely.
Because we felt that in the way that patients have had a hit. Well, first of all, they aged over that time just naturally because 2 years have passed, and some of their conditions could become worse. But also a lot of their resources were depleted because they relied on help from their networks, and as their networks became also strained, because people struggled to keep to make ends meet, and some people lost their jobs and, all sorts of things. And some people experienced very severe COVID cases, including some of our older adults with HIV. That didn't help in terms of their physical health, mental health, but also resource base. And then the next crisis hit when everything was already depleted, so there was both learning and fatigue. And we were actually talking with Tatiana about that, so it could be, for some people, we are afraid it could be the last straw, but then for some people, they can bounce up. And that's partly why we're so looking forward to receiving our results on the Wave 4 data, because they will be probably different, subgroups. To see how different people are doing will be very helpful.
I have to tell you that one of the things that occurred for me, hi Sheila, one of the things that I thought about when you were talking about the fatigue and the burden, that your increased patient burden for the providers, a question that crossed my mind, but you would need a larger sample, is is there an age difference? I mean, I don't know Ukraine and I don't know Ukrainian culture, but just from my kind of experience in this country, are the older providers able to cope? You've used the word stoic. Are they more stoic and they can just soldier on much more than the younger providers that are coming in now? It's a question that I kind of sometimes ask myself in this country. You know, is there a difference in what they're willing to endure?
Yeah, good question. I mean, in our among our people we know, we've contacted, they are people of different ages. So most of them are middle-aged. Some of them are a little bit younger and some of them are quite a bit older. They've been all stoic. So in this particular group, I haven't seen any differences in terms of generation because they all received their education and sort of service, you know, in different times. But they all seem to, you know, go sort of together. One provider mentioned a very insightful thing. So he said that it is important for them to kind of like feel this team support, and so he tried to do that to his colleagues, but he was also the medical director, and he was there with them, like he lived there, you know, he was not leaving, like he was like the captain of the ship, right? So that was his perspective. But he also said that it mattered to people because they kind of looked up to him and he was still going strong, and so they felt reassured by that. So he had that kind of like paternalistic approach to things, but also he pragmatically did, I know for a fact because I talked with him, like, you know, completely like outside of that conversation, so that when he was just starting out and things were very unstable economically in Ukraine, like back in the 90s, he, you know, like found ways to procure very scarce goods, even like food, you know, for his patients, just by, you know, organizing things. And he kind of fell on that same way of doing things now to make things work, like to, of course, you know, he was much more experienced and much more senior in terms of his position. He could do a lot more, so that, for example, he was able to negotiate that all the staff in his clinic would get a little bit of a money bonus for their efforts. It was both symbolic and practical, but also he was negotiating that they wouldn't be laid off if they couldn't travel to their, you know, to their site of work, so that they wouldn't have unemployment looming, you know, even if they had to lose like several weeks of work. And so those types of things that people did were helping, I suppose, to bring like different generations in and sort of like, you know, have the expertise from, you know, from across the board. But it, again, you know, like, does it depend on the specific style of leadership or the specific, you know, conditions in terms of resources or the generation? I think it's a fascinating question, and I hope that, you know, people, including us, can find some answers to that. Maybe Tatiana would like to add something. Like,
probably,
probably
not this time, Yulia.
Okay.
I think you got it well. Yeah, you described it well.
Thank you, Tatiana.
Other people have comments or questions? I know that a lot of people do get off at 1 o'clock. One last issue that kind of struck me as you were describing the study is the issue of stigma. And, you know, we've been talking about stigma for a long time, and, you know, there's the experience, there's the anticipated, but it seems like stigma is still alive and well for both drug use and HIV. And are there efforts to try to reduce stigma, you know, to do something to mitigate the potential risks associated with the whole issue of stigma for HIV and drug use?
Yeah, Yeah, that's a good question. So I think that it's a big question. It's a international question, very much so. So we found a lot of interesting realities connected to that in our fieldwork before the war. That was present in the accounts of older adults with HIV, in the accounts of their caregivers, and in the accounts of clinicians. And stigma is multidimensional, so it's not just regarding HIV. It's very often, related to other statuses and characteristics. It's very complicated. So what we found as an approach to sort of respond to that from our team's perspective was that a lot of that stigma kind of like revolved around this disclosure of HIV status. And the process of making decisions about HIV status disclosure were kind of ways to combat stigma, or at least to make sense of that, and we were empowered by what we learned from the psychiatric community that, look at stigma of mental illness. And some of the approaches that they've been using were to say, okay, well, reducing stigma in the society is a very ungrateful task. So instead of, it shouldn't be completely given up, but that's definitely not the battle that is the single thing that needs to be pursued. So the best way perhaps would be how people can be least affected by that. So even if they do face it, they know what it is, they know how to withstand it, and they know how to not let it harm them, kind of like roll with the punches like panda bears do. And so that's, we thought, was a very wise way, and that's already what people were doing a lot. And so we thought that, like one project that we hope we will be able to start soon, fingers crossed, would deal with the decision aids regarding HIV status disclosure. That's really, about stigma and how people make up their minds about what's best for them, the fear of stigma or the hope for social support. And they have to assess that in the context of their particular set of relationships and make a decision that would be balanced, because unfortunately, there is no guarantee that you would not get stigma. But, sometimes you can either not build it up in your own mind, beyond the level where it's, it's debilitating, or if it does happen, it's not as bad as, as you thought it would be, because there are some techniques of kind of living with it, So that's the approach we were thinking about taking, kind of like at the individual level, because at societal level, I think that all these efforts that we are doing collectively, as a group, not just in Ukraine, but worldwide, empower, I think, people living with HIV, their caregivers, like all these narratives, they give a voice, they give more power to people to not have stigma, and that educates society. So I do believe in the power of education. Maybe it's naive and idealistic, but I do believe in it. And I think that overall, it's not just a problem to be solved by one particular country or one particular group. I think it's collective effort. That's the best I can say, but I hope that maybe colleagues can add to that.
Well, the one thing that struck me was that you said something about that there were many people who used opioids and were on MAT, that they were getting it not through the official, but they were going private pharmacies, and that during the war, they started to go through the regular methadone program.
Yeah.
And my I don't know, my fantasy, or maybe you said something, is that they were treated with respect and valued as a human being by the methadone program that they were accessing when their private methadone supplies went away. And that it's that experience of this is a friendly, respectful place to get my care. It does a lot to, it doesn't necessarily reduce stigma in the grand scheme of things, but at least it reduces, there's one place that they can feel safe and not stigmatized.
Yeah, yeah. Well, that's true. That's also interesting because, you know, like these kinds of places, I've never visited one yet, so I cannot say what they're like. I can only, you know, like know from them about them secondhand. But my feel about them, from conversations with, you know, providers and patients, is that it's kind of like private education. You know, some people, even though they're fantastic public schools and, you know, state universities, they want their children to go to private schools, and they want them to go to private universities and pay a lot of money for that because they think it's better. And they also want to be among better class of people. You know, it's more like a prestige thing. It's more like a sort of like, you know, a way of distinction, social distinction. So there is a lot about that. It's not just, I mean, it is a stigma of a sort. But what I heard is that a lot of people who go to those private places, or at least who used to, they were kind of like better off, you know, employed. Some of them were like senior public figures. So they would be known, you know, people who would be known, and they would only want to be treated by a certain doctor. So they wouldn't always go to private clinics. Sometimes they would have an appointment with, you know, with like an addiction treatment doctor or an HIV doctor. But at a certain time, they would only want to go to the specific. It's like going to Harley Street, you know. It's like this doctor is okay because my friend, who is also like a, you know, like a person like me, you know, like a socially, yeah, Tatiana can comment on that probably better. She knows more about that.
I would just comment and say that, Yulia, what you are describing is just use of private clinics. What I personally do, for example, when I want to come to my specific time and maybe to some specific doctor and pay and receive a good care, not to sit for 3 hours in a line.
Right, exactly.
Like primary doctor at polyclinic, you know. But when we talk about receiving MAT, so-called MAT, because our governmental programs doesn't call these private cabinets or private providers like providing MAT, because MAT, it means the whole like complex of integrated services. And
Right.
here it's just distributing drugs,
Right.
honestly. And the point why people go there, not this is not about like well-established people. This is about people who can, for 35 hryvnias, like for €1 or $1 and less than a half per day, they can receive drugs, enough drugs for them to use and to sell, and they don't need to register anywhere, because the main barriers, one of the main barriers to MAT use is that people still believe there is some narcology register. There is not, but still, like when you go to any kind of medical services, many services providers, you provide your data, right? In any clinic, and the same happens in the MAT clinics. And so people have to be registered, and that is what they're afraid of. They don't want it, first. Second, the requirement to visit the governmental site every day for 3 months, like controlled use, the period of not only induction, but stabilization for 3 months, according to the latest protocols. And here they come and say like, hello, I'm Tatiana, I need drugs. And they will go out with prescription and go to the nearest pharmacy to buy the drugs for cheap. And so, of course, no requirements. And as the providers and governmental sides say, we all the time, we're requiring something from this patient. We want them to change their behavior. We want them to keep some rules. And here, the private providers, they don't need anything, just pay money and you are receiving what you want. And so, as governmental providers said, these programs, these are not actually programs, but like cabinets, providers, they're compromising the governmental program. And they, now some of them are ready to work in terms of the, I mean, within the legislation norms, within the legislation rules. And this is, the process is going on in, I mean, the tendency is that more and more private providers, they're going to collaborate with our national services, national health services, and provide their services within the legislation field. But for now, that's why some people prefer to go to the private clinics.
Yeah.
I'm sorry for talking too long.
No, thank you so much. That's very valuable.
It was, yes, it was very valuable. And Tatiana, the other thing that it really kind of points out, it's the same reasons as people in this country go for services one place and not another. You know, so I talk a lot of times, I quote a psychoanalyst from the earliest 20th century who says that mankind is more human than otherwise, that we share the same qualities no matter where we are in the world, to a lot of point, but at any rate. So, well, thank you very much. We're running out of time. It was wonderful to meet you, Tatiana, and the other person that was there from your project.
Sakina.
Yeah, Sakina. And it's good to see Sheila, if only her photo. So, hi, Sheila. You're on mute.
Sorry, I got out of clinic late. I just want to say thank you to Julia for an excellent discussion, especially so late for time.
Yes, I know. And she's got a meeting after this.
With Sheila.
So.
I'll go easy on her. Don't worry.
Yeah, we gave her a lot of sympathy. We gave her a lot of sympathy.
She's the one who actually called the meeting, so.
Yeah.
Okay. Well, everybody.
We're gonna Julia. Thank you, everyone.
Enjoy your weekend. Thank you so much to all of you for sharing your very, very provocative and insightful study with us. We'll hope to hear more from you in the years to come.
Thank you so much, Lauretta. Thank you, everybody, for having us. And I'm so grateful that Tatiana could join. And, this is work in progress. So, Tatiana, please, let me know your comments afterwards if I have done justice to, what we have learned so far, because it's totally open to, critique and feedback. And
Julia, thank you so much for presenting our results and talking and telling people about what is going on in our country. Thank you so much.
All right, we wish you all the luck and keep up the good work. I'm going to end the meeting now.
We'll do our best.
Bye.